Yeah, now I believe the voice is okay. So, guys, I'll just repeat what I was saying. So, guys, this question paper discussion is a part of the session we have started kind of 4 days back, and today is the fifth day of the session, and it is called as the Triple S session. Now, this Triple S, it stands for Study with Dr. Sakshi and Dr. Sushil. So now this group has been created, or this sessions have been created basically to keep all the FMG students on the track, right, for your June exam. And we are giving you daily schedules. We are giving you topic-wise schedule of all the 19 subjects, making sure that you revise them thoroughly, you revise them very, very properly. And while you are revising your subject, from your own notes or the new notes that you might be making, you are giving the test also at the regular interval, right? That is the whole idea of this triple S session. So we have got a Telegram group also. So if you are the FMG who is targeting the June exam, just join that group and daily schedules will be posted on that group as well. So today, hi, good morning, Namira. Good morning, Shubham, Femina, Medmania. Good morning, everyone. So today I am going to discuss with you the questionnaires of orthopedics of the day one. That was yesterday. Okay, and today morning also, Dr. Sakshi Madam has already given you the topics and which will be posted in a while in your Telegram group as well, right? So try to cover up that today yourself, and tonight 10 p.m. you are going to get the questions from all those topics as well. Okay, so I'll be starting with my questions of orthopedics, and these are the questions which were given to you yesterday night. And let me just tell you the explanations of each one of them. Okay, the first question that you have seen onto the the first question that you see onto the screen, yeah, it is about the first treatment of choice in a post-injection palsy in the radial nerve. Now, if you have made the notes of the nerve injury, we know that the prognosis of the radial nerve is always the best one amongst all the nerves in a body. Why so? What was the reason, guys? Because radial nerve is a pure nerve. Pure means the one which has got only the motor or the sensory components. Now, when you talk about the radial nerve, you know very well that radial nerve starts as a posterior cord continuation in the axilla, and in the axilla, it runs here towards the medial side of the humerus. It goes back through the spiral groove, comes onto the lateral side here, and then it runs very, very superficially. In front of lateral condyle, the nerve divides, right? So, radial nerve, main trunk, the radial nerve itself is only giving the motor branches, right? Once it divides into the superficial branch of radial nerve, it is purely sensory. And the branch which it gives near to the radial head, which goes behind the interosseous membrane, is what you're calling as posterior interosseous membrane, simply because it is going behind the interosseous membrane. So PIN is purely motor, superficial branch is purely sensory, and main radial trunk is again purely motor. So we say it is a pure nerve, and that is why prognosis is best. So anytime we know that the radial nerve will be involved, we have to give or manage most of the cases by dynamic splints only. Remember the splints we've talked about? So what kind of splint do we use here in the radial nerve? It has to be the cock-up splint. I hope you all have got the file of instruments, implants, splints, and traction with you, right? So if you've got the file, wonderful. If not, just download from the group of the FMG. Also, I'll be posting the files in a while. Okay, so download from there. So all the time, it has to be what kind of injury also? That was another question to be asked. What most likely injury we get? The SEDENS classification, you remember? Most often, these are kind of neuroprexias, right? So that is very, very important to remember. So dynamic splint, don't go for exploration of nerve, tendon transfer, nerve grafting. Majority time, the radial nerve will be having neuropraxia, which can be managed simply by conservative modalities. Okay, what are the two terminal branches of the lateral cord of the brachial plexus? The lateral cord of brachial plexus. You know, in the lateral cord, we always learn that in the lateral cord, the main branch, the direct branch that it gives is the musculocutaneous nerve, right? That is a musculocutaneous. At the end, the root, trunk, division, and cords. So when you have the lateral cord, we know that lateral cord is giving the branch as musculocutaneous, the muscle, and the cutaneous muscle, and the cutaneous, which muscle? The biceps, brachialis, coracobrachialis, and cutaneous here, right? Cutaneous is here, upper aspect of the lateral side of forearm. Okay, musculocutaneous. When we talk about the posterior cord, we know the nerve which is given by the posterior cord is the radial nerve, right? And when you talk about the medial cord, the branch which is given by this is ulnar nerve. So from where is the median coming? Median comes from the lateral root of median and the medial root of median, like this. That is how we get the median nerve, right? You might be recalling the brachial plexus as well. Okay, so the answer for this one has to be musculocutaneous as well as the median, because you know the axillary is not coming from the cord area, the terminal branches basically. right? So it comes from only the posterior cord. We are talking about terminal branches. Okay. Then we have this one. You can easily identify what they are. Here, the knuckles are bent. You can see the knuckles are bent, and knuckles are bent for what? To straighten the finger. Why it has been done? Because the deformity would have been definitely the opposite ones. Like if you see the hand like this and you go for the opposite deformity, these MCPs, the knuckles, are going to get into the extension and fingers go into the flexion, right? That is what we call as the claw hand. So if somebody is having a claw hand, how to correct it? We simply have to straighten the fingers, and to straighten the fingers, see, these muscles, these fascias are very, very tight. So we have to relax them. How? We just bend it from the MCP area. And what are these? Knuckles. So we call them knuckle bender splint. Where do we use it? In the deformity, something like this. That is claw hand. So this has to be the knuckle bender splint. I hope everybody would have marked it very, very correctly. Now, when you talk about question number 4, the Tinel sign. Tinel sign is used for which of the following? Tinels, you remember from the nerve? Tinel sign. We were tapping on the course of the nerve, right? Why do we use it? To know about the recovery or the regeneration of the nerve. And we talked that at what rate the nerve regenerates. At what rate the nerve regenerates? The nerve regeneration occurs at the rate of 1 mm per day. Remember, 1 mm per day. So progression in tunnels, it tells you that the nerve is recovering. When you tap on the course of the nerve, the distribution area of the nerve will have the tingling, right? So this is for assessment of the recovery of the nerve. All right. Then we have the decreased mineralization of the epiphyseal plate. You remember the zones of the growth plate? For your just revision purpose, the zones, when you talk the zones of growth plate, if you remember that, what were the zones? We started from epiphyseal side and we ended on to the metaphyseal side. Correct? When you go from epiphysis towards the metaphysis, what were the different zones we talked about of the growth plate? We started from the zone of reserve cells. We started from the zone of reserve cells. Second one was the zone of proliferation, where the cells are proliferating, increasing in number. Then we went on to the zone of hypertrophy, okay, increase in size, and this layer is very, very prone for what? Trauma, remember? And for this trauma of the growth plate, what was the classification that was used? It was Salter and Harris, right? And then we had the lower part of hypertrophy as zone of mineralization, and this zone of mineralization is the one which is receiving the minerals, and if it doesn't get the minerals, the child suffers from rickets. And the last one is the zone of ossification, where we get a proper mature bone, and that zone is called as the ossification zone, which is getting involved in scurvy, right? So zone of mineralization is our zone 4, you can say, or the lower part of zone 3 only, and that is involved in rickets, right? That is involved in rickets. Now you know scurvy will be involved in zone 5. It will be involved in zone 5, right? That is your question number 5. Osteoporosis may be characterized by all of the following except. So in the topic of osteoporosis, if you remember, we talked about that osteoporosis, Paget's disease, osteopetrosis, scurvy, or osteogenesis imperfecta, they are having no link with the mineralization part, right? So mineral disorders are only two, that is rickets and malacia. So when they ask you what can be all like features of the osteoporosis, so you know that the increase in the alkaline phosphatase. Why there should be increase in alkaline phosphatase? It tells you that it is increase in blastic activity. Should there be any increase in blastic activity? Should there be any increase in blastic activity? Actually, no. When the blastic activity decreases down is what you're calling as osteoporosis. Okay, that is a part of our aging process. Okay, and decrease in bone density, yes, that is what osteoporosis is. Number of cells are decreased. The functioning of the cell is decreased. Okay, and can be a loss of muscle mass? Definitely, because we are not doing exercises, we are not mobilizing our limbs, we are not making the muscles contract, and that is one of the reason why we get osteoporotic changes. And loser zone can be seen. See, loser zone are typical features of osteomalacia, right? They are typical features of osteomalacia. Remember loser zone from the pubic area, from the neck of femur, from the olecranon, the ribs, and so on. But yes, in some late cases, malacia, this dietary deficiency is accompanied by osteoporosis. That can be seen. But what can never be seen is actually the serum alkaline phosphatase. So if we have to go with the answer, what will not be seen is A is the better appropriate answer, followed by D, right? So loser zone, we know they are classical for not osteoporosis but for osteomalacia. So giving the advantage, I know that markers are never raised in the osteoporosis. right? They will not be raised in osteoporosis. No change in the blastic activity, right? So for this, if you are unable to recall all the markers, please check your notes for the table of markers. What markers are there for the blast and what markers are there for the osteoclast. All right. Next one. Now this question is a combo of your medicine side and the orthopedic side, right? Brown's tumor. You remember when we were talking about the basics of orthopedics and we talked about the basic anatomy, the physiology, we said bone is made up of three components: the cell, the protein, and the minerals, right? And when we talked about the cellular disorder, in the cells, we have got two problems. Cell increasing its activity, we said Paget's. Cell having no activity or genetic defect is what we called as osteopetrosis. But when the cell is working under the influence of parathyroid gland, right, hyperparathyroidism, then it starts working more, the osteoclast starts working more, and that condition is called as Brown's tumor. It is hyperparathyroidism, increase in pth increase in pth increase in osteoclastic activity. Now this osteoclast, when it resorbs the bone, when there is a resorption of the bone, these are going to kill or resorb the bone. So resorption of the bone, definitely will have some bleed in them. Blood will be red in color. That is hemoglobin. And that hemoglobin, in a couple of, some duration of time, the span of the RBCs, it will turn up into brown color fluid. And that is what you are calling as Brown's tumor. Hemoglobin converting to hemosiderin, right? So it is related to what? Hyperparathyroidism. Another disorder of what? The cells only, right? Another disorders of the cells only. So this is another disorder of cells. Okay. Next one, estimation of osteoid. Now this is somewhat little tricky. Estimation of osteoid is done by, what was osteoid? You remember? Osteoid was when the osteoblast was making the bone, the framework we talked about, right? The framework we talked about. Now, how do you check for the cells? Can you check it by DEXA scan? Can you check it by DEXA scan? No. By DEXA, what do we check? We check for the density, right? That is useful in osteoporosis. Then bone biopsy, it will not be useful to know the counting or about the osteoclastic or the plastic cells, right? Density again, the bone biopsy again will be showing you the architecture, not exactly the real numbers. What we use here is the drug tetracycline. We inject it and we see for the lining created by tetracycline, whenever there is lot of osteoid without a mineral, where there is a lot of osteoid, the cell without a mineral, tetracycline will be able to mark a white line, right? It will show a white line labeled into the bones whenever we give lot of tetracycline. Okay, so this is something you have to add on or learn additionally, that whenever there is a lot of osteoid, what is the easiest way to just check it in the bone? Give the injections of tetracycline, the drug tetracycline, and it will get deposited wherever we have lack of mineralization or lot of osteoid. Okay, fine. Another one, a tricky one. Which of the following inserts into the talus a combo of your anatomy and orthopedic part? We know that talus is a very, very important bone. Reason being, talus has high tendency of getting into, converting into, or getting complication of what? The necrosis, right? But when you talk about the avascular necrosis, we must be very, very clear that talus is one such bone which has got no muscle attachment. Remember, the no muscle attachment. Okay, so talus has got no muscle, it only has the ligaments attached. We talked about the ankle ligaments. So the medial side deltoid ligaments, lateral side the lateral collateral ligament, but no muscle at all. So talus is one unique bone which has got no muscle attached, right? Then we have, which of the shoulder instability is more commonly seen in patients with epilepsy? Remember, when we talked about the shoulder dislocation, 4 points each for the anterior and the posterior dislocation. Now, in anterior dislocation, we said it happens when somebody is trying to throw something, right? What was the attitude there? Abduction and external rotation, right? Abduction and external rotation. But when we talked about posterior dislocation, it has to happen with the arm adducted, with the arm close to the body, right? When the muscle capsule and everything contracts. So it happens in which patients? The patients who are suffering from epilepsy episodes or fall after the electric shock. So patients with epilepsy or electric shock, they usually get posterior dislocation. With very important point, I must remind you here that there is no loss of contour. There is usually no loss of contour, and when there is no loss of contour, when there is no loss of contour, X-ray also shows you something very, very typical. You remember, what do we call it? The head of humerus turning in. Head of humerus turning in. What do you call that? The upper end of humerus, it is the electrical bulb sign. That's what you call the electric bulb sign, right? That would be electrical bulb sign. Okay, so no loss of the contour is a typical feature what you see in the posterior dislocations only. Epilepsy, not only epilepsy, but in the patients of electric shock also. Not only epilepsy, electric shock also. So whenever you get question on this, you know that it has to be posterior dislocation. All right. All are the clinical tests done for the dislocation of shoulder except, so when there is a dislocation, we know that anterior dislocation of shoulder, Dugas was what? Inability to touch opposite shoulder. Now, if I want to touch my opposite shoulder, what movement do I need here? That is internal rotation, which is not possible if there is an anterior dislocation of shoulder, right? Because the head goes anteriorly and gets stuck here in front of glenoid, so it cannot turn in, right? Kave's test is basically looking at the circumference of the axilla. Now, whenever there is a dislocation of the head of humerus, it will stretch upon the anterior axillary border, and therefore the axilla seems to be having a bigger circumferential area, right? Hamilton ruler, you remember that scale test? You put a scale over here and it goes towards my neck or towards the oblique way, never goes towards the elbow area, right? Jerk is a non-specific test. You just give a jerk to the shoulder area and patient becomes apprehensive. Jerk means if somebody is having an anterior dislocation or posterior dislocation, let's say, with the posterior dislocation, keep the arm adducted and give it a gentle push. The patient becomes little apprehensive that the shoulder will dislocate, right? So jerk is a non-specific test which can be used for multiple joints, not only for the shoulder. So Dugas, Hamilton ruler are the two most important tests you must remember. Kave is a non-significant thing which tells you about the circumference of the axilla. All right. Now this one, these are little clinical ones, and I've told you in the class as well while making the notes that why and how you have to catch the words. Young patient reported with valgus deformity. Valgus deformity, the forearm, where is it going? It is going laterally, okay? With valgus deformity of the elbow, with tingling and numbness of the medial border of the hand. Medial border of the hand, 1 and 2. Okay, 1 and 2. What are we talking about? The medial border of the hand involvement is of what? Ulnar nerve. Fracture is where? Fracture is on the deformity is where? Lateral side. The forearm is going lateral. Nerve involved is medial. Okay, and how the injury? Most likely they're asking you which injury does that? Whenever there is a fracture of lateral condyle which goes into non-union, you must recall that fracture lateral condyle were what kind of injuries? They were fracture of necessities. We are supposed to fix them all the time. And then there is a common extensor origin attached over here, which will not allow the bone to be fixed normally, right? This non-union helps in development of valgus, and then it leads to involvement of the ulnar nerve, right? So we are calling not only ulnar nerve, we are calling it tardy ulnar nerve palsy, right? What do we call it? Tardy ulnar nerve involvement, late involvement. The supracondylar, if you remember, supracondylar usually leads to malunion. And what was the most commonest nerve involved in supracondylar? That is again MCQ for us. That is anterior interosseous nerve, which is a branch of your median nerve, right? In front of interosseous membrane, anterior interosseous. Behind the interosseous membrane, post interosseous. That was lateral, this branch of the radial nerve. Okay, so if there is a fracture of medial epicondyle, directly there can be an instant involvement of ulnar nerve. That won't be a tardy one. Direct injury here, direct involvement of the nerve, right? And next one, a 2 year female child, a 2 year female child holding her mother's hand suddenly slept but did not let go of her mother's hand. She continues to cry and does not allow to touch the elbow. Okay, a child is holding mother's hand, so hand of child and mother is holding it. Okay, the attitude of the elbow is pronated. Elbow, actually elbow can't be pronated, we know that, right? Elbow has to be either flexed or extended. The supination pronation, it happens where? At this area, the forearm area, right? What is the probable diagnosis? We know that whenever a hand of a child, the hand of the child is pulled, it usually leads to what? Pulled elbow. What is that pulled elbow? Other name for the pulled elbow we know is also called as the nursemaid's elbow, right? That is called as nursemaid's elbow, and that nursemaid's elbow is seen in any pediatric age group between the 2 to 5 years of age. How does that happen? When somebody is holding the hand of the child and they just pull it, right? With elbow in extension and forearm in pronation, right? So this is what happens, that axial pull. What was the mechanism for this? Axial pull with elbow in extension, axial pull with elbow in extension, and forearm, this forearm in pronation. Okay, forearm towards you, and the kid is asking you, please pick me up, like this. Okay, so you pull it and the radial head comes out. So what is that pulled elbow? It is a radial head subluxation. It is what? The radial head subluxation. So radial head comes out of the annular ligament, right? So it is not a fracture actually. It is just a radial head coming out of the annular ligament, right? There is no specific word to tell you that there can be any fracture or a dislocation. Let's suppose there is a dislocation, then patient will not have only the pronation part. He will only have, in the elbow getting a dislocation, it will always be a flexed elbow. It will always be a flexed elbow because the olecranon will be pulled up. So it is kind of semi-flexed elbow that the patient comes up with, and there is no mobility at all, right? There should be a bony deformity abnormality, which is not given to us in the question. And just pulling the hand, if you pull the hand, the bones actually go down. Why the bone should go up, right? So this is most likely we are dealing with a case of pulled elbow or what we call as nursemaid's elbow. Fracture, identify this. So first thing we have already discussed, whenever you get an X-ray, you must know that first thing to be seen in any X-ray is whether the fracture is intra-articular or extra-articular. Now you can see we have got a breach in the articular margin. So articular fractures of distal radius were which ones? Articular fractures of distal radius were which ones? They were two. We had got Barton and we have got Schoffer. And what was the difference in between them? Barton was comminuted intra-articular fracture, right? Barton was comminuted intra-articular fracture. And Schoffer was what? It was a fracture of radial styloid. It was the fracture of radial styloid, right? And we can see there is an injury to the radial styloid only. Had it been a Colles or Smith injury, they should have been staying away from the joint line here. That would have been the site of Colles and Smith, right? So this is a Schoffer's injury, the Schoffer's fracture. All right. So young male, 15th, the young male who is presenting with a clean wound of 1 centimeter over the tibia, right? Clean wound, 1 centimeter over the tibia. Which grade of injury is this? First of all, which classification is this? You remember the name of the classification? It is Gustilo-Anderson classification. It is Gustilo-Anderson classification. And we know Gustilo-Anderson divides the injuries into three types, type 1, type 2, and type 3. Grade 1, any wound which is clean less than 1 centimeter. Any wound which is more than 1 centimeter goes in grade 2. And when we have extensive soft tissue damage, it goes in grade 3. Grade 3A is what? When we have a patient who has got a segmental or comminuted fracture. Segmental or comminuted fracture. And grade 3C is one when there is an associated vascular injury which needs a surgical repair, right? So this one, our patient is having a case of grade 1 injury of Gustilo-Anderson. Vertebroplasty, when you have to repair the vertebra, which is the most commonly used bone cement, the artificial one, it is the substitute, it is PMMA, polymethyl methacrylate, right? The bone cement, which we can use for trauma, tumors, infection areas. You remember those cemented beads, which we use in cases of infection as well? Uh, which of these is a fracture dislocation? Cervical area, the spine basically. So Jefferson fracture, you remember, it is a fracture of the vertebra C1, the ring, atlas. Then hangman's injury, when somebody is hanged, we usually get a fracture of C2. It's not a simple fracture. We know that after getting injured, the C2 it actually slips, right? In hanging, the C2 it slips. So spondylolisthesis happens of the C2 vertebra over the C3 vertebra. C2 vertebra, after getting a break, it moves ahead, right? That is why we are calling it listhesis. So which of these is a fracture dislocation? They are asking. Fracture also is there, dislocation also is there. So it has to be your hangman's fracture. Clay Schauler, what was that? It was avulsion of the spinous process. Clay Schauler is avulsion of the spinous process of usually which one? The vertebra which is very, very prominent on your back, right? Vertebra prominence. Which one is that? That is C7, right? Sometime T1 also. And whiplash is what? Whiplash is sprained neck, right? Somebody is driving fast, neck goes back, and suddenly you apply the brake and jerk. So hyperextension of the neck followed by sudden flexion, right? So whiplash is sprained neck. Okay, whiplash has to be the sprained neck. Usually vertebrae are not involved, but there can be definitely injury to the soft tissues and maybe sometimes cord as well. Okay, Terry Thomas, you remember that comedian from the UK, Terry Thomas. So Terry Thomas sign is seen around spine. Not exactly. It is seen around the wrist area. right? The Terry Thomas sign is seen around wrist area. What was that? When the scaphoid and lunate were going away from each other. What did we call it? The scapholunate dissociation. You remember the figure of that fellow, the comedian who was based in UK? So he was having gap in between front two teeth, right? So scaphoid and lunate, when they go away from each other, that gap is called as the Terry Thomas sign. Okay. Yeah, surgically done fusion. When a surgeon has to fuse a joint, what do we call it? Surgically done fusion is called as arthrodesis. And when a disease is fusing a joint, we are calling it ankylosis. That is pathological fusion. Pathological fusion. You remember any disease by the name of this? Ankylosing. It is ankylosing spondylitis. Ankylosing of the spondy because of itis, the inflammation of the vertebra, spondy is vertebra, leading to its ankylosis. So when a disease leads to fusion of a joint, we call it ankylosis. And when a surgeon does a fusion of a joint, we call it arthrodesis, right? And the last one we have for the day, it is a Milwaukee brace. Milwaukee brace. Why it is used for? Milwaukee, remember, we were talking about the crook tree, and then we talked about a stick being applied all along with it. Now, what that stick will be doing? You tie it with a rope. Now, as the child keeps on growing, we keeps on increasing the traction onto the child, the chin, the pubis, and the sides of the spine. So, as the child is growing, we keep on increasing the traction so that the spine, which is curved like this, it usually gets corrected with the age, right? That is for Milwaukee. So, Milwaukee will be used in whom? We know Milwaukee will be used in children's. And what about the adolescent age group? What were the other kind of braces to be used? It was Rizzos, it was Boston. So these are other ones which can be used for the adolescent age group as well. So guys, these are the 20 questions that were given to you yesterday night, right? And today, madam has already told you about the topics and you should go through them, read them thoroughly, and I'll be discussing again tomorrow morning all the topics. About the files now, the files of splints, fractions, and the instruments and implants, which are very important for the FMG exam as well. I'll be sharing in a while in your Telegram group, right? That is the SSS group for FMG, Triple S group for the FMG exam, right? So you should have that file with you. And if you have any problem in understanding of those instruments or implants or identifying them, where to use a particular brace, the questionnaires of your past, they have been there from those topics also, right? So feel free to tag me on the group and I'll be more than happy to answer any of your query, right? So I do believe all the students who are watching for the orthopedic part, they have already done, they're covered with the anatomy part. So don't just keep on lingering to the schedule, keep on excelling, keep on taking the new part, new initiatives, and keep on doing the new targets which are being given to you. Don't keep or try to have a big backlog. Whenever you find a window, try to cover it up. It is very much advisable to just cover up the things as soon as possible because the date of your exam is already fixed. You can't change it. So that means we have to be on the track. And if I'm missing out anything, I must make sure that I just cover it very, very soon. Okay. So the complete schedule for the FMG batch will be providing you on the Insta session also, right? And we'll be providing you on the Telegram group also. Follow that, just keep on sticking to that, give the test as we are telling you, and definitely we'll make sure that each one of you is able to give the test as well, right? So that is all from my side. Thank you so much for being with me so early morning, right? So see you all at same time tomorrow morning for the questions of the topics which have been told to you to be done today. All right, so take care and just bye bye. Thank you so much for being there.